This lesson is all about interdisciplinary coordination. The objectives for this lesson are to review the role of each discipline and to define interdisciplinary coordination and review the state of the science, and then to understand the role of the team within this new model of care. The acronym ASK is used for many models of interdisciplinary coordination that articulates how coordination should occur. The A stands for awareness of personal biases towards other disciplines. The S stands for skills to communicate with others effectively. The K stands for knowledge of what other disciplines do. In other words, understanding the difference between OT and PT and exactly what each discipline does. While the E stands for encounters facilitated for effectiveness, and the D stands for desire to work as an interdisciplinary team. Here's our first checkpoint. True or false? Knowledge of other disciplines is required for interdisciplinary coordination. The correct answer is true. You do need to have knowledge of other disciplines to coordinate. So evidence supports that interdisciplinary coordination improves both participant care and safety and access to and coordination of health services. It also reduces mortality rates, clinical error rates, and cost. And it improves communication. It also reduces tension and conflict among clinicians and lets them gain familiarity with diverse situations, which of course is every situation in the My Choice program. Healthcare professionals are known to operate within silos within their own discipline. Studies have shown that if we break down the silos and come together as a team, safety and quality of care are both improved. If you break down the barriers between discipline and each person learns something about the other's discipline, it enriches their own practice. Here's another checkpoint, true or false. Breaking down healthcare silos and coming together as an interdisciplinary team improves safety and quality of care. This is true. Breaking down the silo will improve both safety and quality of care. The National Coalition of Care Coordination has a goal to promote better coordinated healthcare and social services for older adults with multiple chronic conditions. The coalition belief is that care coordination should be an essential part of healthcare reform to improve the quality of life of America's aging population and their caregivers, while more efficiently using limited resources, like within Medicaid programs. Interdisciplinary coordination is a promising element of successful healthcare and long-term service delivery models, like the evidence-based model we're discussing today. Interdisciplinary coordination unites a team of care providers to meet participants' needs and improves healthcare access and outcomes, and can synchronize long-term services and supports. In this successful model of care that's evidence-based, interdisciplinary coordination works closely with the participant family and caregivers, the PCP, and other healthcare professionals to improve communication and collaboration, resulting in improved participant well-being and outcomes. Here's another checkpoint. True or false? Interdisciplinary coordination improves access to care and outcomes. This is true. It improves both access and outcomes. There are initiatives to improve interdisciplinary coordination, but many are still lacking. Those with multiple chronic conditions and a functional impairment in the aging or disabled population need better coordinated care and long-term supports and services. The Center for Medicare and Medicaid Innovation disseminates models like the one we're talking about today to improve the quality of care and reduce costs. So interdisciplinary coordination in this model of care can address the goal to coordinate care for each participant. The purpose, so that all disciplines involved in a case who complete a home visit and do an assessment understand the goals and desires of the participant, the expected outcomes, and problem solve and brainstorm, especially on outstanding issues, to agree on the number and timing and home visits and design the person-centered plan of care. It's feasible to establish a routine time for in-person or phone or Skype brief discussions to coordinate. So here's some recommendations and some examples. So to understand the scope of OT practice, a RN can recognize the OT role, promoting participant independence and function by use of strategies that are designed within the OT's clinical knowledge base, which particularly in this program can be facilitating participant access to and use of DME. A client goal could be fall prevention. The OT can brainstorm with the participant on safe ways to get into the bathtub, while the RN complements but does not duplicate OT services by focusing on participant medications and disease and symptom management, all of which can also reduce or prevent a fall. Or to maintain constant communication with the OT and other members, there needs to be open communication that leads to better participant outcomes and success. To determine the personality and communication styles within the team and use appropriate communication strategies. The RN can attend routine meetings of the team and maintain regular communication with the OT to debrief following participant visits and discuss collaborative approaches to meet a participant's needs. It doesn't need to be time-consuming if we don't make it that way. Another recommendation is to be aware of the OT's activities with participants and reinforce them. By familiarizing yourself with the participant's goals in the plan of care, including all of the strategies that have been selected, you as a RN can reinforce OT activities and teaching. So, for example, the RN could teach balance and strength exercises, while the OT could work with the participant to use a walker and remind the participant to perform exercises. And also, the RN could watch the client use the walker. So, in a team effort, all focused on the same goal, but taking different approaches. Here's a case study of a real-life My Choice participant who received this evidence-based model of care in our pilot study. Prior to receiving care, the participant had been in My Choice for over 4 years. She's a 79-year-old female who lived alone in a house with a history of COPD, arthritis, CHF, coronary artery disease, hypertension, osteoporosis, PVD, and she had TIAs. On assessment, she felt trapped and bored and had difficulty with bathing, transferring, and ambulating due to right-sided weakness. Her goals were to improve her strength and balance, to increase her ability to do her ADLs and prevent falls. Here's her person-centered service plan. Improve her ADL tasks to prevent a fall and improve her mood. To you, these may seem like things that should have been addressed in the My Choice program previously, but they had not been. For this participant, assessments were completed by each of the 3 disciplines. A person-centered brainstorming session between all disciplines with the participant to design the plan of care occurred. The participant desired to focus on 2 goals: to be able to bend over and pick things up, which the OT helped her do by getting a reacher, and to wipe herself and have dignity when she went to the bathroom, so they obtained a wipe stick. This is an example of how the 3 disciplines work together to identify simple, easy-to-use interventions to improve the quality of life for this participant. Although it may take her some time to actually improve her strength and balance and prevent falls, she was committed to a daily exercise program, and the team believed over time she would be able to obtain her goal. The RN and social worker coordinated care in the My Choice program routinely. This has always occurred over years. However, these 3 clinicians believed the difference was intentionally setting aside a time to coordinate and taking some of that time to jointly brainstorm with the participant, which resulted in a focused, person-centered service plan that was more readily fulfilled for her personal desires and goals, and helped her to remain living at home in the community. This was a highly satisfied participant after using this new model of care. She said, otherwise, without the help, I would have had to move in with my kids, and I don't want to go to a nursing home. If I had to move in with someone, I would shrivel up. I'm doing the exercises as I can almost every day. The Reacher has made it easier for me if I drop something, and it's good, and it makes me stronger too. She was satisfied with the content, clinicians, and timing of care. In summary, use of interdisciplinary coordination promotes breaking down the silos of care among disciplines, identification of participant desires, and then focusing on the desire, selecting high-impact, low-cost interventions, and identification of interventions which usually, in my choice, had not occurred but can occur using this model of care. Thank you.